guys, this is Amrit and I'd like to welcome you to OsProEd. This video is for educational purposes only, and please never practice medical skills without the proper credentials. Okay, so I am back today with another exciting topic, which is venous thromboembolism prevention. So VTE related topics are commonly tested on AMC, and I thought it could be helpful to do a video on this topic. So in Australia, the goal of VTE is like standard clinical care. So our goal as doctors, is to make sure we think about the whole venous thromboembolism prevention, and it's something that we need to keep in our mind at all times without failure. Our role as doctors is also to make sure that all adults presenting to the hospital have an assessment. So we need to do a VTE risk assessment as well as like a bleeding risk assessment and document that in the notes. If you think that your patient is not deemed appropriate to get VTE prophylaxis, then you also need to document that properly. When you make good notes and you are on top of your paperwork, you can avoid unnecessary legal battles. If, say, someone developed a VTE related complication under your care, when you follow documentation, it also ensures that VTE prevention is appropriately prescribed and used to reduce unavoidable death or disability from hospital-acquired VTE. Open discussion with the patient is a common practice in Australia. Patients should also receive information about VTE and the risks and benefits of prevention. So like they can, share in the decision making with their clinicians, both in and out of hospital. They can, think about their care and ways to prevent VTE. How do we assess and document VTE risk? So every hospital has their own venous thromboembolism risk assessment tool. Using this tool, we can do two things. Number one, we can look at risk factors. So VTE risk factors can classify a patient low, moderate, or high risk. And common VTE risk factors are things like age, so more than 60 years, obesity, like a BMI of more than 30, moderate to major surgery, or like a surgery involving the abdomen, or surgical time more than 45 minutes, prior history of VTE or known thrombophilia, somebody with like active malignancy or undergoing cancer treatment, somebody with myeloproliferative disease, or acute myocardial infarction or congestive heart failure, or lung disease, active infection or active rheumatic disease, acute inflammatory bowel disease or on hormonal replacement therapy, kidney disease like nephrotic syndrome, somebody with like a venous issue like venous stasis, and there's so many other examples. So we usually go through the assessment tool and try to, find all of these risk factors. Okay, and the second thing that we can do is we can identify contraindications to giving VTE prophylaxis, and so we also look at other conditions to consider with pharmacological prophylaxis. We try to rule out the absolute contraindications, such as a patient already on therapeutic anticoagulation, like say somebody with warfarin or with dabigatran or rivaroxaban or apixaban, a patient having active hemorrhage or thrombocytopenia. We also look at the liver disease or impaired kidney function. Once we have identified the risks and classified someone as low or moderate or high risk and rule out the contraindications, we can then prescribe appropriate VTE prophylaxis, and making sure we document it in the notes and also document the duration of the VTE prophylaxis that we plan on giving. When it comes to VTE prophylaxis, there are pharmacological options and mechanical options. So drugs like Clexane, which is enoxaparin, is the most commonly used. For example, like the drug chart in hospitals, you have an area like a VTE prophylaxis area. Over there, you can start by writing the date and the name of the drug. So you can write over there like enoxaparin or Clexane, the route of the medication. So in this case, it's subcut. So you can write that, and then you can write the dose. So standard like 40 milligrams, as long as they don't have any impaired kidney function. And if they do have an impaired renal function, so we look at the creatinine clearance, and then consider lowering the dose to probably, like, depending on the kidney function, to say subcut 20 milligrams once daily. Other options that can be given are things like rivaroxaban, dabigatran, apixaban, or aspirin. There's so many, so it can be used for other options like pharmacological options depending on case to case. The mechanical options for VTE prophylaxis are things like compression stockings, anti-embolic stockings, intermittent pneumatic compressions or foot impulse devices. Then finally, the duration of the VTE prophylaxis needs to be considered. So for medical patients, duration of therapy will vary with ongoing risk. We usually continue prophylaxis until the patient is no longer at increased risk of VTE. For example, until acute medical condition is stable and mobility returns to baseline, or until hospital discharge. For surgical patients, a rough idea would be, say, like somebody with total hip replacement or hip fracture surgery, to continue for 28 to 35 days. If it's like a total knee replacement, so continue VTE prophylaxis for up to 14 days. Someone with major general surgery, continue up to like 1 week or until mobility returns to baseline. So somebody with like abdominal or pelvic surgery for cancer, we continue for up to like 30 days. The patient should be reassessed whenever the clinical condition changes, or even regularly, like every 7 days as a bare minimum. All right, guys, so that was VTE prophylaxis in a nutshell. I hope this video was useful, and if it was, please hit the like and the subscribe, and see you in the next video. Thank you.